Good afternoon. Those who are connected remotely, we will be starting the meeting in a few minutes. We are just waiting for another member to arrive. Thank you.
And go ahead and call the meeting to order, the Finance Committee. Will the Secretary please call the roll?
Director Deere. Director Deere. Assistant Director Harrington.
Present.
Director Robinson.
Present.
And Chair Ryder.
Here.
You have a quorum.
That's pretty loud. Do we have any, do we need, no one's on remotely?
I don't have any directors on remotely.
All right, we're going to move to the next item. The next regular meeting of the Finance Committee is scheduled for Thursday, July 18th at 10 a.m. Debbie, do we have any public comment?
We did not receive any for today.
All right. So we're going to go to the first action item. The May 20th, 2024 Finance Committee meeting minutes. These were approved by the board at the May meeting, but are being presented for the committee's review and discussion. Are there any corrections that need to be made to the minutes? Any corrections? Any corrections? Hearing none, is there a motion to accept item 3A, the May 20th, 2024 Finance Committee meeting minutes?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right, let's see. Do we have anything listed for 3, 4, and 5?
Oh, 4B.
All right.
I see what you mean. That's the action item number 3B. It's a standing item that basically covers all of the sections that
Gotcha.
have action items in it.
Gotcha. We're going to move now to contracts and procurement. I'm going to ask Charles to join us center stage, as it were. Omar, looks like you're up first, huh? So items 1 through 3. I'm liking the ankle boots. Thank you. I get a front row for everyone's shoes. Claudia, you want to be in this seat.
Chair Ryder, for the record, I would be abstaining and later vote on request number 4 under the contract as present.
Okay. We will note that for the record.
Okay. Good afternoon, Charles Jones, Chief Procurement Officer. We have before you today 33 contract items, of which we have 18 responsive letters back from the Office of Contract Compliance, and 15 are still in process. Thank you.
Okay, good afternoon. So I have 3 that I'll share with you. The first one is an extend contract, South Suburban College, and it has 0 fiscal impact because it reflects a 12-month no-cost extension through May of 25. And what they'll be doing for us is some training, providing training in some of the allied health disciplines as a part of our kind of pipeline programming and making sure we have the workforce for public health. Okay, the second one is also reflects a 12-month no-cost extension. So again, 0 fiscal impact. It is a request to extend. The vendor is the Illinois Public Health Institute, their subgrantee, and this is to provide technical assistance in strengthening our healthcare collaborative system through our jurisdiction, Suburban Cook. And so we have collaboratives with various clinical groups and things, and so they're giving us technical assistance in expanding that. And then lastly is a contract we're asking for an extend and increase. The vendor is Carasoft Technologies with a fiscal impact of $52,000, and they're going to be helping assist us with technical assistance using a platform called Qualtrics. It's a platform that we use for creating surveys and surveying either population or our end users. And so they'll be providing technical assistance to support us in using and expanding this data collection tool. Happy to answer any questions on those 3.
Any questions for Dr. Hasbrook? Just one, slightly curious about
Yes.
The survey. How does that compare to, say, I think Monkey Survey?
Oh, SurveyMonkey.
Yeah, Survey Monkey. Thank you.
Yeah, it's a lot more powerful than that. It's really a survey tool for what they call user experience, and then also some internal operations. So it gives us a lot more power, a lot more flexibility, a lot more design and questions. It does sampling for us, a statistical sampling analysis for us. So it's a lot more powerful tool, a lot more robust and credible. SurveyMonkey is, it's something, it serves its purpose, but it's a very simple platform.
Okay.
Yeah.
It's one of the most it was like one of the first platforms, wasn't it?
Yeah. Yeah.
All right.
Okay, thank you.
Thank you. All right, we're going to move along to items 4 through 7, Health Plan Services, being presented by Aaron Gleaner, our Chief Administrative Officer for Health Plan Services.
Good afternoon, directors. I've got 4 items before you. The first is a no-cost, time-only extension for our vendor, Canary Telehealth. This is to allow time as we post for an RFP, actually reposting this RFP. This next item is also a no-cost extension, so time-only extension for a vendor, Centauri Health Solutions, that provides member support applying for SSI and SSDI benefits. This next item is an increase to a contract for Beta Data Solutions. This is a vendor we were recently implementing for provider data support and solutioning. These changes reflect some of the regulatory changes that have happened to ensure that we align with compliance that CMS has came out with in the past 12 months or so around provider directory information. And then the final item I have is our dental and vision benefits. This is a new contract as a result of an RFP process, 3 years for Visas third-party administrators, and the administrative fees associated with that is $9.9 million over the life of the contract. Happy to answer any questions.
Any questions for Aaron on any of these items? Hearing none, thank you. We're going to move now to items 8 through 9 that are going to be presented for behavioral health, presented by Dr. Thomas Nutter, our Chief Behavioral Health Officer.
Actually, Dr. Nutter has a conflict for today, so Carlos will present.
All right. Thank you, Carlos.
All right, the first request is for a new contract, sole source with NAMI to be able to provide a referral crisis line and then be able to connect patients to providers, behavioral health providers in the county. This is for 2.5 years through the end of fiscal year 2026 for a total of about $7.9 million.
How does the person in need actually get the number?
It's actually available widely through the internet. They publicize it, and a lot of folks, if you just look up behavioral health crisis, NAMI will come out, and that's usually the number one after the 211. And part of what they're going to do is also connect to the 211 provider so they can actually then transfer over to NAMI.
Okay.
The next request is to ask for additional, it's a new contract to expand our naloxone vending machines, and this is to use the same vendor and be able to increase from currently, we've got 11, and we are looking to expand to 30 to 40 vending machines, mostly at commuter locations. And that's it.
Any questions for Carlos? Hearing none. Thank you, Carlos. We're now going to move to items 10 through 12, being presented by Dr. Claudia Fegan, our Chief Medical Officer.
Good afternoon. So the first one is, this is Rush. Okay. All right. There we go. Yeah, so this is a clinical service agreement with Rush to provide, to supplement our services with direct patient care for providers that we do not have in the health system. All right, why is this match for this? Okay, the next one is for ophthalmology. These are for provide, services, for our patients for vision. These are the pumps. Yeah. So, yeah, these are the, pumps and stents for patients with glaucoma.
Okay.
Yeah, this is for more, for our, more of the structural health work that we're doing. This is a monitoring system that allows us to divide the screens that, when the, physicians are doing, procedures so that they can see, more than one image at the same time. This is, really important when we're doing the, structural procedures, so you can see the results of the echo while you're looking at the angio.
I'm always happy to see more equipment for heart procedures.
Okay, that's it. Thank you.
All right. Thank you, Claudia. We're going to now move to request number 13, Equity and Inclusion. Shannon Andrews, our Chief Equity and Inclusion Officer.
Good afternoon. I have one item in front of you today, and this is a request to amend and increase a contract with In His Hands Resources. Resource Center. This is an ARPA-funded contract. These additional dollars will allow for increased service capacity for this vendor who's awarded a contract via an RFP to provide housing navigation services throughout the city of Chicago as a part of a three-part RFP to provide services across the county.
Is it just city or city and county?
This particular vendor is for the city. We issued an RFP and we broke our services into 3 regions. And so the remainder of the county is serviced by 2 different providers.
Thank you.
Thank you.
So is this actually used for patients that come through that you find that have a need for housing?
Yes, they refer, they provide wraparound services in terms of connectivity, work with a number of other CBOs and social service agencies across, quite frankly, not just the county, but the state, in terms of ensuring that folks have access and or assistance in addressing housing and security needs.
So if there are members of county care that have that need, do they have the same access, or is it primarily for the hospital?
It's quite frankly the way the ARPA funding programming that we receive dollars from Cook County allow. We work in partnership with County Care, and so it is a part of a network of organizations and or resources that allow us to make certain that we're reaching and impacting, quite frankly, all of those folks who encounter housing insecurity needs throughout the system. So to the extent, there's nothing in the language of the contract or the ARPA funding that would put us in a position where we could not provide assistance to someone in County Care. But having said that, County Care has robust programming on its own, and because we work as a collaborative and are in constant communication, it really ensures that where there are holes or gaps by any one system, that there are a number of resources in place to provide that type of assistance.
Great, thank you.
You're welcome.
Do we know, so how much, because it's ARPA funded, this is going to be time limited probably to this contract once we identify other funds after we exhaust these funds, or is there still a rolling amount of money that we're looking to fund this program in the future, or is it still like a quasi-pilot?
I would argue that what the ARPA funding allowed us to do, as you know, we had a housing director. We currently have an interim housing director. We work very closely with County Care. We had some programming. This allowed us to expand our programming. And so the short answer is if ARPA went away, we have an infrastructure to provide some support. What ARPA dollars have done is has really allowed us to level up, if you will, the type of support that we do. And this is just one of many things, as a part of our housing efforts with ARPA that we've been able to expand.
Yeah, I guess the question, because this comes up with people, is that what happens when we're done with the ARPA funding? What will happen to this program?
We're actually doing that exercise now for all of the ARPA projects,
Okay.
not just the housing, to kind of triage what's going to come on our budget, what are we going to kind of try to find other sources for,
Gotcha.
keep going, and then what we're going through that exercise right now to kind of to work through all of the ARPA funding and the projects that we have, triaging kind of each of them to see what are we going to bring onto the hospital
Gotcha.
budget. Yeah.
Gotcha. And then, I think just to go ask a similar question of what Sam asked, how do you get to the housing navigator? Like, if you're, is it, because we talked about county care, if you're a county care member getting services for something at another institution, I'm guessing that whatever county care has available through their network is going to get accessed first. Are these navigators that we're deploying through this contract, are they on site here, or is it a number that's given to people? Is there community outreach? How are we accessing the navigator? How's the community accessing?
So it's really all of the above. I'm actually working with Shantae Gamby, our current interim housing director, in terms of identifying space at various sites. They have some space. They've been primarily housed and focused on the south side of the city. We're looking to expand where they have space, but they have phone numbers, they have business cards, and I think what is amazing, and it's not lost on me that the former housing director here is now the housing leader for the state, there is a robust coalition of organizations and community stakeholders who work together. I mean, you'd be amazed. There's a housing consortium, and so what happens is, while it is a very widespread, it is a very well-connected community of resources, and so to the extent, oftentimes the referrals will come from other agencies, social service agencies that are working on various issues that say, here's a master list of resources that are available to anyone who has a housing insecurity need throughout the state, certainly within the county. Let's look through those resources. And so they can be referred in ways that are beyond simply just who's in front of a, let's say, social worker or care provider within the organization in the moment. You could have been a client, a patient here 2 months later based on issues that arise in some other area of your life when someone who has access to or is working with you and they make that connect, they will say, here are housing navigators who can assist you by way of your relationship and or connectivity with Cook County Health. And so I would argue, while there are the obvious ways in terms of having the navigators engaged by the 3 vendors spread across the county proper, the more critical piece is making certain that at the point of entry for people in terms of being able to identify that they have housing security needs, that we are very present and people are aware of how to contact the various programs for assistance.
All right.
Yeah.
I'm sorry. Well, I was just going to say one other thing that I've been thinking a lot about is how we, and this is the first time I'm thinking about it in the context of the hospital, but how we can leverage services provided by the clerk's office to the, using space that the court system or their county offices have, more cross-pollination of, physical location throughout the county, and also working with some of our villages and to bring county services maybe to some of those locations, sort of like what the Secretary of State's office does, where, like in my community, the Secretary of State's office actually has a driver's license, vehicle, kiosk set up at the township building. So it's not a Secretary of State's building. I don't even think the Secretary of State pays rent. I think it's an intergovernmental agreement for like $1 probably a year or something, but you know, I'm just thinking about how to leverage that to make sure that we have a presence in, you know, more communities in that type of way,
No,
whether it's with collateral or people, you know.
no, absolutely, and we are certainly looking, constantly looking at ways to be expansive in the obvious places and also the not so obvious places. So I appreciate that feedback and can certainly circle back to give a more comprehensive list of the various ways that we have entry points to making certain that we're trying to reach the community that's in need. But thank you for that.
Director Harrington, I think, had a question or comment.
It's not a comment, but, well, maybe it is a comment more than a question, because I know it's not a question. But we all know that the ARPA funding is going to disappear. And I'm assuming that with the ARPA funding, we were able to do more than were previous to the ARPA funding. And so it'd be helpful for us to know how much of a change or how much of an improvement you saw relative to the money that you've received, and let us know what we will not be able to do moving forward and how that's impacted upon the health of those people that got the services.
Absolutely.
Might be able to make an argument that maybe we need to find the money.
Absolutely. I think that's a great point. And to Dr. Makaitis' point, I think we also were very thoughtful across perhaps all of our ARPA programming that to the extent that there's data collection, that we're collecting data in a way that supports not only the success, but the need on a go-forth basis. So thank you.
Yeah, there's a direct correlation between stable housing and health.
Absolutely. Absolutely. Thank you so much.
I have another question. This is drill down specific, because I think this is an extremely important area. And these two subjects that I think, one of them really shocked me when I found out, the other I've known about probably literally all my life. How does this program impact homeless families? And I was really shocked during COVID to find out just how many homeless children actually exist inside of CPS, because my children, well, one of them used to go there, now the other one's still there. And there were a lot of students, and they didn't know until you see students showing up because they couldn't get a meal. And so how do we help those homeless families with children? And also, how do we help the homeless vets?
No, I think and again, that's the unique nature of the collaborative and the partners that are in the space, is that they are, I think all three of our partners, one being Beds Plus, the second being Housing Forward, and the third being In His Hands Resource Center, has a unique insight to where there are opportunities across the county. And so, you know, at a very base level, what that means is that they are all uniquely aware where there are opportunities in housing that has been identified just for women, where there is housing opportunities and or programs that fit the needs of families. I mean, right down to the micro level of where are the places that you send people who have families with children under 12, where are the places that you send, I don't know that that's the number, but like it is the level of direction that you can provide can peel down to where are there services available for non-English speaking, where are there services available for people with teenagers, where are there services for teenagers who have no families. And so we were very prescriptive in terms of identifying partners by way of the RFP process to get people not who have to learn about housing, but who have a proven record of being, if you will, subject matter experts in how to navigate the larger process, because there is no better example of a space where it requires a village to map out how best to address the needs. And so it's a collaboration that, quite frankly, stems all the way to Springfield in terms of a collective space of providing information and or resources. And that's not just the brick and mortars of it, but also where's the programming, where's the funding, where are there additional resources to tie folks in. Now, having said that, I think it puts us in a unique position to be able to focus our efforts on those people where we know ultimately housing impacts health for everyone. For people who are flowing through our system, it can be even more heightened to the extent that folks are discharged from places or provided instructions for services or instruction for how to extend and or improve their health care. And if they don't have a home, that is difficult to do. So we certainly are proud to be a part of the collaborative and the larger groups, and they are all uniquely aware and tied into those systems that provide the type of insight that you're suggesting exist as it relates to the unique nature of any one person and or family's need.
I'm the one who sort of got us off on this tangent. I'm just gonna close it with one comment, and we'll move on to Pam. The one challenge with all of this is that housing insecurity is one of our largest problems that we deal with as a community, a broad community. The programs that address them, though, they have to deal with a lot of different factors, because housing insecurity it's not just a homeless problem. It's a problem that has a variety of different causes. So it's a problem that, we need to continue to work on, and it requires a lot of complex solutions, because it's not as simple as just finding someone a place to sleep. Usually there's a lot more wraparound that has to go into that. So thank you, Shannon. We're going to move to request number 14, which is under finance. Pam Gassara, our Chief Financial Officer.
Great, thanks, Chair Ryder. We do have one request before you today. This is for revenue cycle. It is a request to extend and increase a contract with Electra Inc., which is a software service provider that we use the software to capture and submit data on our cancer program to keep our accreditation status. This is a request for 1 year. This was originally awarded through RFP, and the idea would be to extend it until we can go out for another RFP. Any questions?
I think this one's straightforward. I don't know that we need to have a long policy discussion on this one. Thank you, Pam. Request number 15 and 16, Human Resources, Carrie Permavolk, our Interim Chief HR Officer.
Good afternoon.
Good afternoon.
Good afternoon.
Okay, the first one up is an extension through the rest of this fiscal year for Deloitte. We have the contract ended at the end of May, the last extension. However, we had need, as we're going through an RFP process, to extend two particular services with Deloitte to get us through the RFP process, and that is what this extension is, and would bring us to the end, to November, to allow for transition of services to whoever is successful through the RFP. This last one is grant-funded emergency medical technician apprenticeship program. Is to serve the apprenticeship program is to serve youth ages 18 to 24, and it's healthcare-focused apprenticeship that is. We are utilizing Jump Hire to assist in the educational resources and connecting these youths to EMTB licensure, as well as upskilling and training these apprentices to be certified in crisis intervention training and psychological first aid.
All right, thank you, Carrie. Unless there's any questions, we're going to move now to Dr. Vina Peters, who will present request number 17.
Good afternoon, all. The first request is to purchase the the first one is to purchase the GI scope equipment for our Stroger campus to replace those old equipments, as well as to have a 48-month service plan for all those GI scopes needed at the Stroger campus. The next request is to purchase the neonatal ICU equipment beds, as well as the different treatment equipment. This is also a replacement for the current equipment, and this particular request is funded through one of our grants, Human Services grant. Any questions?
Any questions for Bina on request number 17? Hearing none. Thank you. We also have you on request number 18. Let's do it.
Let's do it. I did, this is to replace or purchase equipment for our neonatal ICU, the neonatal beds, the giraffe, the warmers, as well as some of the phototherapy machines. And this particular funding is through one of the HHS grant. Questions?
Any questions for Bina on request number 18? Hearing none, thank you, Bina. And we're going to now move to request number 19 through 25, operations and development. Craig Williams, our Chief Administrative Officer.
Before I start,
Craig, I feel like you weren't here last time.
that might be right.
Yeah.
I think I did miss one.
Yeah.
I know you look forward to it.
Well, you have a very important job and your contracts are all very important. There's usually a lot of them, so.
Yeah.
But six is pretty low for you guys.
Yeah.
So.
Yeah, before I start, I did want to see if the committee wanted to, make anything in the minutes recognizing the Celtics being the verge of their 18th NBA championship.
I'm sorry, what?
I didn't know if you wanted to put anything in the minutes about
Are you
the
from
Celtics being on
Boston?
the verge of their 18th NBA championship. I don't know if you know, they're up 3-0 in the finals.
Give your report.
All right, sorry. The first one I have is for Moise's contract.
You know what? You better be careful. See, if you have a medical problem while you're on campus, Claudia's got control. Do no harm, but don't screw with the Bulls.
I know that all too well. This first one is an amended extend contract with no fiscal impact, 12-month contract period, 7/1/24 through 6/30/25. And this is continued landscaping services for all the ACHN clinics. This is our second renewal option. This firm will just be providing landscaping for our new Bronzeville location, as well as our new outpatient pharmacy, which are new locations we've just brought on board. The rest of our landscaping has gone to a countywide contract. Next one is Lindy. It's an extended increased contract for $500,000. It's a 12-month contract period, 4/1/24 through 3/31/25. And this is to provide preventive maintenance, inspection, repairs on a medical gas at Stroger and Providence. Olivio Medical Center is an extended increased contract for $155,400, 6-month contract extension, 5/1/24 through 11/30/24. And Olivio provides consulting and staffing services to Stroger's OBGYN program to improve its cultural competency. They provide patient community facilitators with bilingual personnel to work with patients to navigate the OB system. Parada Systems is an execute contract for $10,550,000. It's contract period is 7/1/24 through 6/30/33. And this is to supply and install pharmacy automated prescription dispensing system at our new mail order pharmacy, Central Fill Pharmacy. And this will cover training, commissioning, maintenance, and extended service. They were selected via an RFP with two-year renewal options. And you can see that gap in the implementation. We're building out the new outpatient pharmacy, so that's why there's the maintenance and stuff at 27. The next one is also Parada Systems. It's an X2 contract for $1,382,000. It's a capital one-time purchase with a 36-month extended service plan. And this is for Cermak, and this is the technology that does the pill packaging for prescription distribution throughout the facility. And it's a sole source because they provide standardization with our current system. Cintas is a execute contract for $500,000, 6-month contract period, 7/1/24 through 6/30/29. And this is for uniform rental and regular uniform cleaning services throughout our system. I had one more. This last one is also Parada. It's an execute contract for $486,000, one-time capital purchase with 36-month extended service plan, and this is to provide the Provident Blue Island Pharmacy with a automated pharmacy prescription filling robot and a mini automated dispenser. This will cover installation, training, extended service maintenance plans.
All right. Any questions for Craig on anything?
One question, I'm not sure if this may be for Charles. This is a carryover from the previous Finance Committee meeting. One of the directors asked me a question, which I didn't have an answer to, so I thought I would ask you. When we have, like, for instance, with Parada, there are 3 different items here. Is there an MSA that governs all of this?
No, sir, in this case, we're doing all individual contracts because there are 3 different modalities and 3 different places for it. I mean, there's times that we have done it and we can do it, but for this instance, we're doing 3 separate agreements.
Okay. So it's not advantageous in this scenario to do an MSA? Not challenging, I'm just trying to be able to give the answer back to the person who asked me the question.
I think it has to do, I think it would have to do with if ultimately the contract falls under Craig, but if other department heads are actively managing the contract and there was 3 separate contracts under that department head under Craig, then an MSA might make sense. But I'm guessing an MSA doesn't make sense for this because the contractor is doing 3 completely different things for 3 completely different
3 different modalities. But as well, too, the first one was led from an RFP. So that's an RFP, and then the other 2 were sole source. Based on continuous services with the product we already had in place at these different.
So it's also a question of whether there's a competitive bid process or whether they're a sole source for that particular service.
Yeah. Okay, so I think I understand what I can tell the person that they asked me and I didn't have an answer for them.
Well, also have them reach out to me if necessary as well, too. I don't mind taking the call.
Yeah. That way you don't have to be a filter. The only other thing that I have is if I had to make a choice, I would probably pick the Celtics over the Mavs.
Good to hear.
Yeah.
Good.
But basketball season's over for us here in Chicago. The Bulls may be the last sports team I could say I have any affinity for here in town. So especially if you're a Southside baseball fan like me, but baseball ended a long time ago.
It's been 1,939 days since we won a championship, so it's been quite a drought for us.
Yeah. I think the Lakers may have a little something to say about that.
Yeah. Well, I do long for the days of Larry Bird. Well, all right. I think we still have more stuff. Let me look. Provident Hospital, number 26. Dr. Turner, welcome. Our Chief Hospital Executive for Provident.
Good afternoon. This is a request to execute the contract with Stryker GPO to purchase new stretchers at Provident to meet the service need throughout the hospital, including the ED, transportation, and the PACU. It's for $248,786.80. This includes 20 stretchers with scales, which have a full service coverage for the first 24 months. It also includes a service plan. This is a one-time capital purchase with a 36-month service plan.
Any questions for Dr. Turner? All right, thank you, Dr. Turner. We're going to move to request number 27 through 33. They all had to sit somewhere, so they're with you, Donica. Donica, Austin, Kathy, our Chief Hospital Executive for Stroger.
Thank you and good afternoon. Okay, the first one before us is an extended and increased contract for trials in the amount not to exceed $1,100,200. The revised contract period of 4/1/2024 through 3/31/2025. The vendor will continue to process pharmacy transactions and manage pharmacy connectivity between the pharmacy health plans, government agencies, and pharmaceutical manufacturers. Next, Next up is an execute contract with Boston Scientific in the amount of $1,500,000. The contract period is 7/1/2024 through 6/30/2027. The request is to purchase specialty interventional peripheral supplies and accessories currently in use for the peripheral interventions. The supplies will be used for the medical procedures.
We'll have to take care of it. Cheryl spoke there.
The next one is an execute contract for GE Precision Healthcare. And this one is in the amount of $1,426,627.11. It's a one-time capital purchase. This is for the provision of 3 X-ray systems for Schroeder Hospital. The vendor will also perform a turnkey installation solution for this equipment. And these 3 X-rays, 2 will be for the emergency department and 1 to support our inpatient services. Next is an execute contract for Stryker Neurovascular in the amount not to exceed $1,350,000. The contract period is 7/1/2024 through 6/30/2027. This request is for the continued provision of supplies used in our neurovascular interventional angiography department for neuroradiology endovascular cases. Alrighty. The next one is an execute contract for Argonne Medical Devices in the amount not to exceed $300,000. Contract period 7/1/2024 through 6/30/2027. The request is for the provision of specialty medical products, including a broad line of devices and supplies currently for the interventional angiography vascular suite. This is a sole source because this vendor is able to provide the retrievable inferior vena cava filters. The next one is an execute contract for Profunda for pharmaceutical in the amount of $200,000. The contract period is 7/1/2024 through 6/30/2027. Improvito is the drug needed for the treatment of cutaneous, mucosal, and visceral leishmaniasis in patients 12 years of age and older. This request is a sole source because this vendor is the sole distributor for this pharmaceutical. The last one is an execute contract for Vision RT Inc. in the amount not to exceed $160,713. The contract period is 7/1/2024 through 6/30/2027. This vendor will provide 3 years of maintenance and support services for the Vision RT system located in our radiation oncology division. The application also tracks patients' position during their radiation therapy treatments and the treatment accuracy. Any questions? Thank you.
All right, thank you, Donica. Got number 34 on here twice. I just think that's, is it? Okay, all right. Well, first, let's go for behavioral health with Dr. Nutter. Oh, Carlos, sorry. The role of Dr. Nutter today will be played by...
He's actually done a podcast.
Huh?
He's actually done a podcast.
Oh, is he really?
Yeah, Chief Jones.
All right. You're up.
All right, this is, to be able to, pay HRDI for services they provided, operated, and running the Community Triage Center at, Roseland. A contract, ended in November, and then an RFP was issued to continue providing those services. HRDI was awarded that contract. The board approved the new contract that actually starts in May. However, HRDI was providing those services from December until the start of the new contract in May. So we're asking for, funds to be able to pay in the amount of it's gonna be about $66,000 per month, for those months, that they provided services without a contract. And, then, we'll start paying them out of the new contract.
All right, great. Thank you. So we can get some clarity, these are two different, you're good, though. Why do we have two things under the same request number? Why wouldn't they have two request numbers?
It is the same type of request. It's request for approval of expenditure, payment of bills. And there was a question of whether to do it on a separate sheet of paper. It's unlikely. It's been unlikely that one would be approved as opposed to not both of them.
I would just make 134,
Okay.
135.99. Because I think it would be confusing under a FOIA. It'd be more. Yeah, but they're still checks are being cut to different people, so. All right, request number 34B. Dr. Turner.
Good afternoon. DNY provided the locum tenens for the emergency physicians that allowed us to resume ambulance services. The contract ended in August. We were able to successfully hire into those positions, but some of the physicians that were hired weren't able to start until November. This is to cover the physician services that required to get to November during that September through October period. This will close out the contract. We no longer require the services of DNY. This is to pay it off.
Any questions for Dr. Turner? All right.
Closing it out.
Awesome. All right, then with that, I would accept a motion to approve item 4A, contracts and procurement items containing request numbers 1 through 34-ish, subject to completion of review by contract compliance.
So moved.
Motion's been made. Is there a second?
Second.
You know what, I'm gonna second the motion because you're abstaining from one of them.
Okay.
So, and let's note that, Sam's, abstaining from request number 4.
Request number 4 under the 4A contracts and procurement items.
Yeah, correct. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Aye. The ayes opposed, the ayes have it, with the note of the, of Sam's, voting present on request number 4. Moving along, we've got the, MBWB reports. Charles?
Yes, sir.
All right, let's do it.
All right, and bear with me as I give you the 4 months of the year and get caught up, and then next month we'll have just the month of May, single entry. So going all the way from your left here, for the month of January, you approved 32 contracts, and of those 32, 13 of them had contract-specific goals for a little bit over $25 million. Of those 13, we had one MBWB service, a prime contract for $720,000, a little bit 3%, and then 10 subcontractors for $4 million and 4.044 million. So 11 total contracts of participation for a little bit around $4.7 million, and approximately 19% of participation out of those contracts. Unfortunately, we had 2 waivers, and I like to say unfortunately because I would love to always have participation on everything. 2 waivers for $2.9 million, with the contract for sleep disorder and breathing treatment equipment for $1.8 million. And then we had the courier services for delivery of the lab supplies, $1.16 million, that received the full waiver. Moving to the second column, February, there was 10 contracts that had contract-specific goals for $65.6 million. Unfortunately, no participation there as a prime. However, we did have 8 of those 10 as subcontractors for a little bit over 21.4 million. So 8 total vendors with participation out of the 10, a little bit around $21.4 million, and or 33% of participation. Likewise, for the month of February, we did have 2 more full waivers, and that was the contract with Interactive Text Communications with members on behalf of County Care Health Plan for $207,000, and the patient payment collection process support services contract for revenue cycle for $3 million, so $3.2 million there of a waiver. March, 10 contracts came before you. 3 were Go specific. Again, we had no primes, but 3 as subcontractors for $2.05 million and 13% of that participation. So no, great news, no waivers for the month of March. And then lastly, the second to last column to the right for the month of April, 14 contracts had goals, $121.8 million. 4 of those were prime MWBE vendors, $775,000, 1%. 7 of them had subcontracting participation, so $42.4 million. All in total, 11 contracts had participation, a little bit over $43 million, 43.34 to be exact, or 36% of the total participation there. Likewise, we had 3 full waivers that particular month. The healthcare specific budgeting and financial reporting system contract for $557,000 had a full waiver. The physicist and radiation professional services contract for $372,000 had a waiver. And then the mail order pharmacy call center service contract for $1.3 million. So all in all, $2.29 million represented those 3 waivers and those 2 contracts. All right. So lastly, so looking year to date, all the way over to the right, the final entry, 40 contracts, $228 million had goals. 5 of those, 1.4, were prime, and 28 of them, and $70 million were subcontractors. So all in all, there was 33 contracts of the 40 that had participation, approximately $71.4 million of participation, and around 31% there. So Debbie, next slide, and we'll see the barcode chart. I'm a visual kind of person, so there you are with the 19, 33, 13, 36, and then a year-to-date 31% participation. Any question on any of the MWBE metrics for the last 4 months?
Any questions for Charles on the MWBE report? Hearing none, thanks, Charles, on that one. And then report of emergency purchases. I know that there's one being presented.
Yes, sir. On May 15th, we notified the chair of the board and the chair of finance of an emergency purchase to provide executive search on behalf of the Department of Administration with Honnold Associates LLC. It was a 12-month contract, again, for executive services, and a not-to-exceed value of $150,000.
Any question on this?
Emergency purchase.
Hearing none,
Thank you.
we'll move on. And I believe that concludes your various reports, Charles.
Yes, sir.
Thank you so much. We're going to move now to items under the Chief Financial Officer, Pam Casara, who is, I believe, going to first report on grant award related items.
Thank you. Pam Casara, Chief Financial Officer. Before you, you have a receive and file grant awards and renewals, summarized $1.29 million. 2 of those are new awards and 2 of them are renewals. And the executive sponsors are here if there are any questions.
Any questions on any of these grant award related items? Hearing none, Is there a motion to receive and file item 5A, the grant award related items?
So moved.
Motion's been made. Is there a second?
Second.
Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed, the ayes have it. Pam, can you now do your report on the April financials?
Absolutely, thank you. Reporting on the 5 months ended April 30th, pleased to report that CCH ended April with 121.9 million favorable variance to budget on an accrual basis. And on a cash basis, the county is also showing us favorable at 23.1 million. As reported, yeah, that's fine, Debbie, go ahead. As you can see here on this slide, that 121.9 million favorable variance is comprised of a 268.9 million favorable revenue variance. And looking down through that variance column, you can see that the bulk of that is coming from the higher than budgeted county care capitation revenue related to the higher than budgeted membership. And then as you glance down through the variance column on the expense side, 115.6 million unfavorable variance, again being driven primarily from that medical claims expense line, driven by the higher than budgeted county care claims that go along with the higher than budgeted county care membership. Next slide. So volumes are what drive our financial performance, and again, here all the variances, with a few exceptions, are in the black. So we're pulling ahead of budget on our volumes, which again translates to good finances on the hospital and clinic side, as well as the better than budgeted membership is driving the financial performance on the county care side. The only lagging, and this was through April, performance indicator was surgery, but those are very, we built in the budget, you know, some growth there that has happened, that is coming and has happened. However, it's just a little bit less than we budgeted. That variance actually breaks down to less than one surgery per day, so at each facility. So if Stroger had done one more surgery per day since December 1 to April 30, they'd be meeting their budget, and it's less than one at Providence. So again, through April, very, very close on all the volume budgets, and I think, spoiler alert, as we move into the May and June time period, you'll see us actually pull ahead of budget. Next slide. This slide just illustrates those same key volumes that drive our financials over time. And again, just drawing your attention to the 2020 dip. Everything has come back and or increased since the pandemic. Next slide. We're keeping an eye again on payer mix just as we continue to go through the redetermination process. You can see the Medicaid there has been a slight downtick year to date and a corresponding uptick in the uncompensated. However, we are, you know, both on the county care side and on the hospital and clinic side, you know, reaching out to all patients as they cross our doorstep to get them re-upped with their Medicaid paperwork. Next slide. Payer mix. Key performance indicators for revenue cycle. Again, as we reported, the Change Healthcare cyber attack back in February has impacted the revenue cycle. Key performance indicators, they're missing on quite a few of their indicators related to that due to not being able to send the bills out and then get the cash back in. However, we are continue to work through that and do anticipate that'll be cleaned up before the end of the year. Next slide. Denials, they continue to do well on, both in terms of the key performance indicator there is to be less than 2% of their cash collections. They've hit that pretty consistently the last several years. And then the smaller box graphs there, they are also, we want that to trend down, those graphs, and they're trending down in terms of both the government denials and the underlying reasons, the box in the bottom right there, all the underlying reasons for denials we continue to improve on. Next slide. Charity and public program expenditures. This slide just illustrates sort of beyond the traditional charity care and uncompensated care, which is bad debt, but the other services we provide, CCH provides to the community, both including CIRMAC and the Department of Public Health. You can see again that there is a slight uptick in the charity care. However, this is just an annualization of the year-to-date numbers, and it could come back down a little as the year goes on. But it is pretty consistent across the years, and in terms of our percent of our revenues and percent of our costs, also pretty consistent. Next slide. Savings initiatives, we're a little bit behind on this year as well. We would hope to be at 5/12 for the way through, or 42%. We're hitting about 28. And again, those items in yellow are related to rev cycle and being a little bit behind related to the Change Healthcare cleanup, as well as some of those contracts were actually slated to not start till later in the year. And again, we anticipate that'll get caught up by the end of the year. And then lastly, county care. Again, the story here is the membership, the graph at the bottom. County care came in at 2.5 million. The budget was basically to be zero. And the budget, as you can see, the blue bars budgeted significantly less membership than the red bars, which is the actual membership, hence their good financial performance this year. Any questions?
Yes. You made a small statement, but it was a very loud one. You said that we're above the 2020 numbers?
Above the 2020, the pandemic, yes. All our volumes took a dip in 2020, and they have since recovered and in some cases surpassed those levels.
So I think that's pretty big.
Yeah.
That's giant.
Yes, we like to see growth, and actually that's a good segue. We're in the process of building our 2025 budget as we speak. Next month when we come, we'll be presenting that to the board, to the finance committee and the board. And we'd like to build in some growth, right? We like to have enough growth to cover our raises and our increases in our supply contracts, right? Inflationary increases. And so we do, but we have to have strategies in place, right? Which Andrea comes and gives her update on what are those strategies. And for the last several years, they've been a continuation of basically the same sorts of things. Expanding services at Provident, increasing surgery, getting providers hired, and those will continue into next year as well. But we do like to see at least, some growth enough. The county's goal is for us to break even, and we need some growth, right? We need more revenue coming in the door to offset the raises and the supply cost increases.
So what do you attribute the growth to? I know county care. I know that's loud and clear. What else?
Yeah, but all the things that Andrea has presented in the strategic plan, in her strategic plan updates, again, it's primarily expanding services at Stroger, surgeries, help me out.
Yeah, we've seen some growth at Provident as well. We opened the ED to ambulance runs again. We saw a pretty nice increase when that happened. And then there's a huge part of this where, we're one-off by surgeries, but our same-day cancellation rates, I think, offer some opportunities, right? So looking forward, it's still not brand-new strategies, but I think it's a lot of, kind of how do we continue to improve on the things that we're doing right now to drive additional volumes where we're able to,
One effective strategy is execution.
Absolutely.
Yeah. And there, as Dr. Makeda said, there's a lot of optimization as well, which, if we can move patients through faster, then we can backfill with more patients, right?
Since you brought up optimization, I'm just curious. Do you guys employ Six Sigma?
We do. If you remember Andrea Ramel from the quality team, she comes and kind of does the high-level operational excellence. She's trained in that. She has one team member already on board.
Green belt, black belt, what is she?
It's black belt, yeah. Well, the equivalent. She went through simpler. It's a different nomenclature, same idea though. And then Amelia Nichols is part of her team as well, also trained in LSS, Lean Six Sigma. And we have another person onboarding. We're hiring a third position right now in that realm. A lot of our quality team has those credentials, but they're not directly involved in PI. They help support, but primarily Andrea and Amelia are the ones doing that.
Okay, that's very good.
Anything else?
No, not from me. Thank you.
Thank you.
All right. Thanks, Pam. Last item on our agenda is our quarterly update on the VIA contract, which will see Dr. Peters and Charles both return to the desk or the table in front of us.
Good afternoon again. Next slide. It's our pleasure to present our quarterly VIA, which is a nursing contract, to the Finance Committee. So this is the standing agenda for us, the scope of the contract implementation benefits, new contracts, and some of the recruitment challenges, as well as we also will go through the county recognized MBA, WBE usage, and some other information. Next slide. So it's just shared with you in the past, the VIA contract provides labor management services for nursing and support staff position across the Cook County Health System. And also this is a contract we are using for any emergencies as well as, peak in our volume. So our goal is due to the current nursing vacancies and also emergency staffing needs. This contract will supplement the existing workforce to provide safe quality care while we are actively recruiting the vacancies. Next slide. So significant benefit to this contract is centralize the whole contract management process. Now we have more than or close to 60 agencies. Previously, prior to IA, we only had 6 agencies, and we had quite a bit unfilled and vacant agency requests. And also, we increased the agency.
So Beena, I'm going to jump in here just for the interest of time and background. I think these are all known things. I think the biggest thing that I would like to know on this, you guys correct me if I'm wrong. I just want to know how while I think we understand the necessity of making sure that we have folks staffed. What's our declination rate on reliance on this contract as we're filling nurse vacancies? Where are we at trajectory wise to be able to scale down the Vizia contract? I think we all understand that we consolidated this contract, that there's a master contract that was all that consternation. Some people who aren't here may want to revisit that. I think this group's probably most concerned about when are we going to be less reliant on it? So.
Oh, thank you. I like that. So we can take 2, 3
Let's
slides
get right
and
to
go
it.
to the rate to it, right? So, we have active plan in place, HR. I don't see my colleague here. Our total FTE growth is pretty steady. That means, we have not gone down significantly. However, the next slides tell us the story about the cost. Next slide. The one before that. Contract labor spent. I know last June or May we talked about the goal was to decrease the cost of the agency by 20%, and as of March, April, we decreased it by close to 34%, and mainly those activities were related to actively managing the contract rates. So that's a process in place. We do have opportunity to look at our hiring velocity as well as to decrease the vacancy, and that's what the priority for our HR team in partnership with nursing and the whole team.
So the story here is that our spend is down on this. Looks like it's down but flat month to month right now. Mm-hmm. So.
That is correct, because we kind of actively work on the rate, and now rate is around, $98, $95. Right. That got stabilized for the last month.
So then, I get that. So that's rates. What about live people? I think that's ultimate, because that drives a lot of things, including morale.
That is absolutely correct, but we have not achieved that to our targeted goals. And
let's see where we're at on that.
Next slide. Maybe the one before. And this is the FTE. So if you can see, if you look at from the FTE or head, count perspective, we have not, gained much momentum, as well as in the last 2 months, our hiring velocity pretty flat or below the gain, the minus number.
So the green bars is how many full-time employees we have or positions that we have?
These are the filled vacant agency position we have, people that we have now to cover the gap.
Okay. And then the red line is showing how that's dropped. So it's dropped. The green lines don't look like they drop much, but the orangish, reddish line is showing that over time it's gone down.
Yeah, there's a trend down, yeah. And remember, it's starting December of 22. Also, the the
Well, there's a-
pandemic time.
Looks like there's a tick back up, so I just don't know how it also shows it's down year over year, but I guess let's see, that's comparing it to March, which was, March of '23, which was a particularly high month in all of this.
So, Bina, just to clarify, does this include our work at the landing zone with new arrivals and all of that?
Yes, this
Okay.
is the whole.
So we had a huge uptick in
that's
early
good.
'24, where we expanded out to the landing zone as well as,
Gotcha.
stood up like 12 mobile units to go out to the shelters.
Gotcha.
And one of the interesting things is to see that it dropped to, I guess in December, and that was the lowest drop, and then it went back up, and then can't say it's a trend, it went back down, so hopefully we will stay at least that level. Numbers will be flat.
But I think, so what Joe's talking about now, though, is that's the same period of time that encompasses when we scaled back up for, new arrivals.
In early '24.
Yeah. Okay. All right.
And also, we also have a slight uptake in our volume. That also contributes when we have more volume, and we see steady that volume when we look at the agency to manage that too.
Do you have the attrition rate?
For the agency,
No, for full-time staff, because, I mean, ultimately, one of the drivers of this is whether we're hiring at attrition or exceeding attrition based on the fact that we have more vacancies. Pam? Can you step up so they can pick up on the microphone?
So Carrie had to step out, but I do have her May report, which shows that we have, and this is not just nurses, but we have a net new of 118 through the end of May. So that is hires minus separations. So we've only netted, right, 118 new bodies to the organization in total.
That's for what time period?
This fiscal year, December 1 to May 31.
That's all positions,
All positions, not just nursing.
not just nurses.
So we're hiring more people than we're losing on that figure.
Right.
Okay. I'd like to get that figure that we can circulate to the members of the committee ahead of the next board meeting. That, where we're at relative to nurse attrition and filling of positions. So we could see whether I've seen it, I think the last time I looked at this number, we were hiring more nurses than we were losing. It wasn't at a trajectory to get us up to filling all the nurse vacancies
Right.
quickly, but it was a positive number, which I think was the first time we had that in a while. So I'd just like to see that number.
that is correct. If I recall correctly, my February, March report, we gained close to 62 extra body of nursing bodies, and now I don't have the data, which I have it. I need to take a look at it between March, April, May, and see what that's going to look like. So we do separate the attrition rate for nursing and the gains.
Okay.
Happy to share.
So here's a question, because we're getting down to the brass tacks, but the question still remains, and it's great that the cost has gone down, but there are quite a few drivers that can contribute that. Some of them are completely out of our control. And, but the morale part is not gonna be impacted by that number. So the next question becomes, it seems as though we are doing the right things to try to get the people, but we're still not moving at a rate that will really dig us out of our hole. We're treading water, and hopefully we've all had lifeguard training, because or either Navy training, because we're struggling to get the people. So the question I have is, if you had a magic wand, what would you give us that would allow us to get more yeses? Because we're getting a lot of at-bats, but we don't have a good batting average of bringing people in as far as meeting the goal. I will agree to things that I've seen, it seems like we're improving, but we're still not moving the needle the way we need to. So if you had your magic wand, what would you give us that would allow us to actually move the needle to get more people and to fill the vacancies at a rate that'll allow us to achieve it in the tenure of the board.
Excellent, question, Dr. Robinson, and this is the one I definitely want to give an answer, in partnership with HR. Because from a nursing perspective, we have all the positions out there for recruitment. So we just need to come together and talk about what that magic bullet look like. So if I say it here, I want to, make sure the HR is, in this conversation.
That's fair. Yeah, that's fair. I'm looking, Carrie has some of this stuff in her reports that, the slide I'm looking at is about offers, which isn't necessarily acceptances. So, we'll get numbers from Bina and Carrie to bring us up to date on this.
Right, because the thing that I'm trying to get to is that whether it be within the board's ability or the conversation comes a lot, if we're getting enough at bats, then that means that we're doing something wrong that we don't know why people are saying no. And that's the question that we need to answer to be able to move the needle faster. And that's where we've got to, and I know we do the interviews after someone says no, but we're still not finding the answer. So we have to keep asking different questions and digging deeper inside of us, because we'll never get there, and we'll be continuing to say the same thing without asking these harder questions. Whether it be we got the wrong people interviewing, or we're not putting forth the best attributes of the organization that'll make people say yes. But we've got to get an answer.
And Carrie may have some of that information, because she has slides on it, I think was that from her last HR report?
We had an HR committee meeting in May, and this, there were other slides relating to nurse hiring. It may not address exactly what you're looking for, but I can also resend that if someone wants to.
We can resend that, so look for that in your email, and we can also maybe have Carrie do and Bina come back at our next finance committee meeting to give a supplemental report and circulate any information they have relative to this in an interim before our next board meeting, which we still have 2 weeks for the next board meeting. So, Joe?
This is a broader question. This is still a national problem. It's not just a local problem, and even other hospitals, neighboring hospitals, are having the same problems with nurses.
Nursing vacancy rate perspective, I have one more slide, and I just wanted to use the slide to answer your question. So from a nursing turnover, right, there's two factors contribute to the agency or the nursing staffing is turnover and the vacancy. From a turnover perspective, we are actually one of the best in the country, because the 90th percentile turnover is 14.2, which is you want to be on the high. We are actually here today is 5.4, right? So that piece we got. We have nursing, retention committee, frontline staff participating. So we have lots of program built into that. However, our vacancy rate is much higher compared to our neighbors. We are getting, we are higher.
Yeah.
And national average is declining. So we have to come up with a process to catch up with our fill rate.
Yeah. So the problem isn't keeping the nurses here. It's that we haven't kept up, and I think this was a much bigger problem. Maybe it's still a problem. It's not we're now on the right side of the problem. We're meeting it in terms of on the turnover, but we're not filling the problem that we created. Like, I'm just going to pull a number out of my 10 years ago, or leading up to 4 years ago or 6 years ago. So, Bina, I would think you would say that we're in a much better position on our fill rate than what we had been in your experience here, and you've been here, what now?
5 years and 6 months.
I was going to say 6 years, so I overestimated a little bit.
Yeah, you're absolutely right, that 2021, few years I don't like to reflect much, but the velocity of hiring was much negative numbers. We are catching up, but I think we have to look at our hiring, see what else we can, and I'm really looking forward to that.
Once people get in here, they don't want to let go of the improved health care that we provided for the staff and also for, their retirement benefits. All right. Anything else?
The highlights are those 3 slides.
All right.
We also talked about providing this update, review or evaluating, do we want to do quarterly or every 6 months? Last May,
Right.
that we'll review that later. So it's not-
We'll stick with quarterly right now, just because we keep having questions and wanting to clarify updates, because it's important. We get a lot of public comment on nurse contracting. I think that the attention on it is, there was a lot of different things that people were looking at on this contract in terms of how many contracts and then consolidating the contracts. But I think also what has emerged is more like, when are these contracts, are we gonna be reliant on these contracts only for surges and normal turnover versus filling vacancies that we never kept up with hiring for, so.
Happy to come back we'll
Okay.
come back.
Well, you'll be here anyway,
Anyway.
right? You're here anyway. Okay, perfect. Thank you, Bina, thank you, Charles. And with that, the plane is landing. We've exhausted our agenda, so unless anyone has anything else, the meeting's adjourned. Thank you.
Where'd you go?
There you go. Use your helmet.
No, you can't do that.
I was going.
Now it's official.
All right.